Thank you very much. Thank you, Dr. Khanna, for organizing a wonderful course, and I'm sure it's going to be of great benefit to all gathered here. And Dr. Henry, it's really an honor to have a session chaired by you. Thank you very much for giving me that opportunity. I'm going to try and talk to you something about a case that we came across actually about five months ago, and this was a patient who was 75 years old with the comorbid conditions of coronary artery disease, and he had chronic obstructive airways disease, so obviously he was not a good candidate for any open intervention, and he came to us with a practically asymptomatic aortic aneurysm. He had a pulsatile mass and his complaints were very classic. He felt that his heart had slipped into his abdomen. So basically he used to have this thing which used to be pulsating when he used to sleep. So that was the way he came to us, and we, of course, an ultrasound proved that he had an aneurysm, and we put him through a CT scan, a CT scan, and as you can see here, I'm going to just show you the case in a PowerPoint presentation because of shortage of time. But here, as you can see, this is the the aorta at the level of the renals, and you can see both the renals here, and this is the right renal. The distance between the shortest, the lowest renal and the point from where the aneurysm took off was less than 6 millimeters. It was less than 6 millimeters, and there was a fairly large chunk of thrombus which was lying in that area. So obviously, technically speaking, this patient was unfit for an EVAR because of the short neck. We then decided to go ahead and do something different. I had actually seen Frank Criado talk about what was called a chimney operation. And these were what were called chimney grafts. They first started off with Roy Greenberg, who used them to depress the proximal edge of the stent graft fabric that protruded a few millimeters above the renal artery ostium. And now it is accidentally, it is actually used intentionally in segments where we want an additional segment of the neck so that we can actually deploy a stent graft and still have a reasonably accurate apposition against the aortic valve. This is not something which is still standardized, in the sense that there are a lot of questions. This is not something which is the final answer for a situation like this, but better, other than a fenestrated graft or a branched endograft, this is another option that can be used to take care of such situations. As you can see here, it's a schematic representation of what a chimney graft means. Basically, this means that the aortic aneurysm, the covered segment of the EVAR endoprosthesis is actually overlying or covering the renal ostia, and you have two covered stents entering the renal arteries on both sides, thereby getting perfused in an antegrade fashion, just as they would, allowing antegrade flow into the aneurysm. So this is what a chimney graft means, and this is what is now increasingly being employed even for the great arch and the vessels. Both the carotids and even the subclavian arteries have been managed by some presenters, Roy Greenberg being one of them, and of course Frank Criado, who's talked about, I think that on last count, I'm sure he's done more. Last count he talked about some 24 odd cases that he had done with reasonably good short-term results. So this is what it looked like, and this is what is the final answer, the final CT scan, which shows adequate perfusion of both the renal arteries. So I'll show you what we did. We went ahead, and this is just the still films. As I said, you can see a renal artery here, and you can see one renal, very faintly visualized renal artery here between them. And between this and where the aneurysm and the thrombus starts is less than 6 millimeters on measurements. Now we came down from the left brachial approach into and cannulated the right renal artery, and then went ahead and cannulated the left renal artery through the right brachial approach, and now we secured the ostia and both the renal arteries, and then went in and put in 2 covered stents, the Atrium Rebron stents, 6 mm by 40 millimeters in length, and these were placed in the renal artery, exposing them beyond the inferiorly introduced thoracic, the aortic endograft. This was a Cook device, Zenith device, which was placed, which was pushed up from one of the femoral arteries. And here you can see both these stents in position along with a top cap which is being released of the Zenith device. And this is the top cap removed, and you can see both the stents are in position with the 2 wires in the renal arteries, and the fabric has actually not, the top ends of the stent grafts in the renal arteries are above the fabric which starts from here. This is the stents being blown up, and this is the final completion, completion of the aortic aneurysm with deployment of both the legs. And this is the fixation with all 3 balloons up together, so that there is an adequate fixation and around the aortic aneurysm at the neck. And this is what it looks like at the end of the procedure. And you can see both the renal arteries adequately perfused with no proximal endoleak and the stent graft in position. So this is how it was placed at that point. And this is a 1 month late CT scan. As you can see, both the renal arteries well perfused up into the renals with no proximal endoleak and an endograft which is positioned the way it is shown. So this is how we manage this patient with a 6 millimeter neck with a thrombus lining the top, with 2 chimney grafts into the renals. Now, I'm sure there'll be a lot of questions. I'm sure there are a lot of queries about what about the proximal sealing, whether there is a leakage which occurs from the sides, because it's not a complete approximation. As you can see that there is a infolding of the graft which occurs, which would have to occur if it has to accommodate the 2 chimneys coming up from the sides. But it works in the short term, and people have talked about it for the last 9, I think now almost 12 months. People have been talking about it, and this is something that I think in a situation like in which we were, in which this patient had an aneurysm, and he had a bad obstructive airways disease, he had significant coronary artery disease, was unfit for an open surgery, and the aneurysm on the diameter was 9.4 centimeters across. So something needed to be done. His children were very, very adamant that something needed to be done, because obviously they had one of their kids was in the United States and had read about rupture of aortic aneurysms and was desperate to have some treatment done. So that is the case, and now I would request.
The topic is open for discussion. Any questions from fellow moderators? Any questions from the audience?
The renal stent would need to be very strong so it doesn't get compressed and the flow is maintained.
That's right. That's right. The Atrium Rebron stent is what we have used, and it seems to work in the sense that, as you can see, there's a fairly good flow into the stents at the end of a year. Can we have that stent back? Yeah. Just let that be, please. Thanks. And you can see that there is an adequate flow into the kidneys even a month later. So obviously they seem to be working. As I said, I'm not saying that this is the answer and that's the best treatment, but it can be something that can be considered as an option in these cases.
How do you apply it to the neck vessel?
The same way, you can come up the brachial. Come up the brachial into the subclavian, and you can do that, or you can actually go retrograde into the carotids. In fact, that's the way it has been described. Puncture the carotids, go down into the aortic arch, and put in both the stents into both the carotid arteries, and then layer the stent beyond that, so that you can then open up in the arch beyond the origin of the great vessels. It has been done. In fact, I don't know whether they've been done. I don't know if the Cook guys have we done any one of the arch these things in India? Yeah. So the Cook thoracic endograph has been deployed, I think, in Trivandrum. Where was this? Vellore. So they have done one case? Two cases in which thoracic endographs have been placed with two chimneys into the carotids.